one of the things that you mentioned in the conversation on the Zoom call was as you go through the process of unroofing and you are making that slight incision, I'm assuming very delicate incision with a lot of haptic feel, you also denerve.
Yeah,
And I think that was a new word for a lot of us. Can you
right,
explain
right.
what that means?
Okay, I will start with a disclaimer, if you permit me, Jeff, that this theory
Absolutely.
of denervation is just it doesn't have scientific foundation under it yet. It's just our theory in our team because we often see that the myocardial bridge is very, very small. People target the myocardial bridge, unroof the myocardial bridge, but then patients turn out retaining their symptoms. There is no difference. I'm sure you can tell there are hundreds or thousands out there who went through unroofing and their symptomatology remained the same. It's all for nothing, basically. So, in our practice, as I said, in order to not miss any potential thin fibers that are crossing over, right from the beginning, I was unroofing all the way, basically over a long stretch of the LAD or any other vessel. And so then I realized how come our patients turn out to have almost excellent results. I mean, at some point we need to gather them and publish them with long follow-ups. And I realized that, and I did some thorough search, and I'm working with a university professor in Greece as well, and a larger team who are doing a thorough search. Now, there is a mechanism in the LAD and any coronary artery that is affected by the surface nerves on top of the artery. It's the outer layer of the artery. Those nerves can have impact on the constriction or the dilatation of the coronary artery. Usually, what they do is they release a hormone, a substance, which is called acetylcholine. This acetylcholine infiltrates through the wall and causes impact on the endothelial cells. This is the inner lining of the vessel, and normally causes the vessel to constrict. Now, in myocardial bridge, there is enough literature out there that proves that that interaction is disturbed. And instead of causing dilatation of the vessel, it causes constriction of the vessel. Add on a second physiological impact which we found. After the squeeze, there is a massive acceleration of the blood because of the squeeze. So it's like the Bernoulli effect in the pipe, in a vessel. You know the hose in your garden? If
Yes.
you press it at the exit, then the water will jump farther away. So there is an acceleration of blood right after the bridge or at the middle of the bridge already, causing this blood to accelerate towards the end of the vessel. And so the branches, the preceding branches right after the bridge, don't get enough blood. So we call this a steal phenomenon. Steal as in robbery, stealing.
Hmm.
So these two physiological phenomena seem to have an impact on the symptomatology um, as the bridge itself. So, and by unroofing thoroughly on the arrested heart all the way up and not just going desperately for a 1 centimeter bridge, seems to affect that denervation process. That means these nerves on the outer layer probably are cut or made dysfunctional. In many cases, I do see the vessel beautifully blowing up, basically, becoming bigger and more round, you know?
You mean immediately after you unroof it?
Yes, immediately. And
That quickly?
yeah, not in all
Wow.
patients, but in many patients where this eventually takes effect. And in order to keep record of this, when I do my unroofings, I use an additional device called high frequency ultrasound. It's the market name, the brand name is Medistim, and it has a special epicardial probe, a little probe which you put on the vessel, and you can see right under the surface of the heart. You can assess the artery. It's the Medistim Mira Q, Mira as in Mira Q, and I'm using this before I start cutting and afterwards to compare before and after. So our quality assurance is there. It helps me guide and find the bridge, but it also shows me the improvement on the flow right after that. Again, it's not always the same in every patient, but it's an additional guide.
Well, and I'm sure that also gives you some sort of tangible evidence of
Right.
change in that artery
Right. Right. And
because,
right. And
as I think that,
the most telling evidence, and sorry to interrupt you, Jeff, the most
no, it's fine.
telling evidence is the symptoms of the patients we'll see afterwards. Remember, unroofing a myocardial bridge may not result in immediate total relief of symptoms. It may be an ongoing process of recovery. In a certain percentage of patients, we're not sure, 20%, 30% may not experience a symptomatic relief. But what in our patient group cohort, what basically confirms that our strategy is perhaps right is the fact that the vast majority of our patients experience a symptomatic relief.
If I can take just a little bit of a step back, because it's a question I've asked of all of our doctors, professors that we've had on, is we know that the condition causes a starvation of blood to the heart,
Right,
which in some cases causes a myocardial infarction,
right.
or even worse, a full-on heart attack with damage and everything else. I personally had a heart attack, fortunately no damage, but it did cause an MI. As much as we all hate to say, no, that wasn't. It was we just
Yeah,
had an
yeah.
incident. But is it possible, if the estimates are that there's 25 to 30% of the population, global population, just humanity, has a myocardial bridge, of which a small percentage are symptomatic, we understand. But is it not possible that some of them may be asymptomatic until one time and they actually die?
Well, there is this quote: "There is nothing in medicine that there isn't there." So that means everything is possible. In other words, we have seen all kinds of borderline situations. But Jeff, the reality is unlikely. We have to distinguish at this point a myocardial bridge, a true myocardial bridge with an element of vasospasm with a post-bridge acceleration. We must separate this from an intramyocardial cause of a vessel, which we surgeons see during the bypass surgery all the time. That means
Mhm,
the vessel gradually dives under a thin layer of muscle and then disappears. That's a very frequent situation. That's not
mhm.
equal myocardial bridge. So you are right, indeed, even of all those patients, you throw them in a pot, only a small percentage will have a symptomatic myocardial bridge. Now, the myocardial bridge, other than causing severe and debilitating symptoms, is also known to cause earlier onset of coronary artery disease. I mean, real atherosclerotic disease with blockages of the coronary arteries. In fact, in many of the patients I unroof, even though they are young people, I do see a premature thickening of the vessel wall, like the starting process of atherosclerosis, the true, disease that causes bypass surgery,
Yes.
uh, right in front of the myocardial bridge. As for this, the muscle damage, the ischemia you mentioned, this is also the reason, because of the acceleration of the flow and the still phenomenon. You see, the LED is running right over the septum of the heart. The septum is the muscle that separates the left heart chamber and the right heart chamber. And the LED gives rise to a lot of small septal branches that feed this septum. So, because of the acceleration, the blood doesn't have the time to go into those septal branches. So, what is
Mhm.
the end muscle, the end organ that feeds from these branches? Is your septum. And therefore, it bulges, and because it swells, it's stunned for a little while. And this phenomenon, the septal stunning or the septal bulging, is well described in myocardial bridge patients. So, it's a temporary relative ischemia caused by the bridge.
I think that's a wonderful explanation, and it leads me to believe that while the bridge directly isn't the cause of a potential heart attack,
Right,
but it could be the cause of another symptom it creates or another
right,
condition it creates,
right,
and then
right.
it has to be either be rectified or you could die from it.
Absolutely. I mean, very unlikely though. I mean, I haven't. It may have happened somewhere in the world where patients have not been followed up. Uh, from the myocardial bridge patients I know, nobody thankfully has died ever. But
Hmm.
there is a likelihood of a heart attack. There is also a likelihood that the coronary artery disease, which is a too degenerative disease of the vessel inner wall, will set on earlier in life compared to, in quotation marks, normal patients.
Yes, and our other doctors have explained the same
Yeah,
situation where the artery thickens
yeah,
or occludes, could be both, where it enters
right, right,
that heart for a variety of different reasons, and in some cases necessitates a bypass.
yeah,
And certainly, the older you are, the more likely you are to have
yeah.
an incident or an issue where there's a problem there. You know, a lot of your cohorts and peers, and I mean, in the professional medical world, the greater professional medical world, not your cardiac thoracic surgeons, but cardiologists for sure, still are not on board with these myocardial bridges. If you could say something to them as a result of your experience and what you've seen and what you've done so far, what could you say? What would you say to help move them along to better diagnose people who
Right.
really are symptomatic, who are just being dismissed?
Well, number one, take the patient seriously. The reason I joined this group is because I suffer with the patients, meaning that I see how much confusion and desperation is there. And the solution is an operation that, my goodness, takes 30 minutes. It's not a big deal for an
Mhm,
experienced heart surgeon. So take the disease seriously and don't send the patients to the psychiatrist. I know hundreds of patients with myocardial bridge because the bridge itself is not objectifiable in the existing diagnostic methods. They are sent to psychiatrists. Definitely,
mhm,
the patients may need some psychological consultation. Who wouldn't with a chronic condition? But my advice is take them seriously. Number two advice would be study. Study deeply and understand the mechanism of this disease. And don't wait until the head drops off the shoulders of the patient to initiate definitive treatment, which is unroofing. Number
mhm.
three, regardless your background, whether you're a cardiologist, general surgeon, thoracic surgeon, cardiac surgeon, study the outcomes and results so far and don't go and offer the patient a bypass surgery or a stenting. I recommend against stenting. We don't need to turn a non-endothelial disease into an endothelial disease. I've seen also enough myocardial bridge patients who have been stented because they presented in some emergency department. All the preceding diagnoses were ignored and the patient is sent in for stenting, which turns the young patient into a coronary artery patient. And then the stent
Yes.
broke. And then they went in and put a bypass distally to the stent. So the right treatment for this disease is the proper extensive arrested heart unroofing and to address both the bridge and eventually vasospasm as good as we can. So educate yourselves. Take the time, that will be my last advice, take the time to talk to these patients. On average, again, on a cordial and light-hearted note for our audience, a normal consultation of a patient in my busy schedule takes me about 15 to 30 minutes. For a myocardial bridge patient, I take 2 hours because they happen to be educated, very clear about their condition, they have tons of questions, and the doctor must take his time to address all those questions. It's even medico-legally sound, so no question is left uncovered. No doubts.